Hi everyone, I am Dr. Sandeep Sharma. I am MD Pediatrics from PGH Chandigarh. Now, if I start with the topic, why it is important, as I said, questions have been asked in NEETPG 22 as well as INICET May 22. The topic is often asked in MBBS theory and practical viva. It is relevant for FMGE exam with clinical scenario based questions expected in next one. This is going to be relevant, and this topic is not updated in many of the current Indian textbooks. So let us begin with the discussion. First thing, there are a few terminologies to remember. Understanding the meaning of these terminologies is very important. The first thing that you need to remember is HIV-exposed infant or child. The term exposure does not mean कि बच्चा is infected. What it means is that he has been born to a pregnant female who was diagnosed with HIV positive status, right? तो अगर एक HIV positive mother bears a baby, we call the baby as HIV exposed. अब whether the child is infected or not, वो एक अलग issue है. But all children born to HIV positive mothers, all children born to HIV positive mothers until HIV can be either excluded or confirmed are called as HIV exposed infant. This is the first term that you need to remember. Second thing is MTCT, mother to child transmission. Any HIV transmission occurring during pregnancy, labor or breastfeeding from the pregnant female to the baby or postnatally during breastfeeding to the child is called as mother to child transmission. Mother to child transmission is sometimes synonymously used with vertical transmission. And the third terminology which you will encounter in an Indian second is PTCT, that is parent to child transmission. See, if you say mother to child transmission, in our society there will be a bias where people will start holding the mother responsible for infection, and the father will, sometimes he can say, I am absolved of my responsibility. That is why in Indian context, PTCT is the term which is used in favor of replacement of MTCT as the term. तो अगर कोई पूछे what is MTCT, what is PTCT, essentially same. MTCT in India is sometimes called as PTCT, right? तो कोई difference नहीं है, होता mother से ही transmitted है, but father also has a responsibility in the management, and that is why we call it as PTCT. So these are the three terms that you should remember. With this in mind, a few facts or epidemiology relevant for MCQs are important. First thing is MTCT, that is mother to child transmission or vertical transmission, is responsible for up to 90% of all childhood HIV infection. If you look at the past papers, in one of the older papers, there was a statement related to the percentages which were asked. Now, it's an old question. It was asked in one of the Central Institute exams when they used to be held separately, but still it is a relevant percentage point that you should remember. It's a past MCQ one-liner. MTCT is responsible for 90% of all childhood HIV infection. Second thing is, what is the target MTCT rate? Target is 5% होना चाहिए या उससे less. And what is the current rate? You will be astonished to see. In 2020 in India, it is 27.4%. Yes, my dear students, it is 27.4, more than 5 times expected. Yes, we have been making good progress in that. Some years back, it used to be about 40%, but now it has reduced to 27.4%. Still, there is a lot of scope in improvement. So this is something which you must remember if they are asked in the exam. Now let's move further and talk about the key features and synopsis. The first thing that we need to know is what is the immediate care at birth that you are going to get. Now, as soon as the child is born, normally routine wiping of nose and mouth is sometimes done, sometimes not done. In HIV exposed children, whenever they are born, you have to wipe the mouth as well as the nose of the child. So wiping of mouth and nose of the child is very, very important. Right? This is the first thing. Second thing is wearing the gloves. You should not be handling the child without wearing sterile gloves because there is a chance of exposure of the healthcare personnel to the infection. Thirdly, cord clamping. This is very important. Whenever you have to do cord clamping, early cord clamping should be preferred in these children. So early cord clamping is the one which is preferred. No milking of the cord should be done. No delayed cord clamping is recommended in patients, in children who are born to HIV positive mothers. So these are the 3 points related to immediate care at birth that you must remember. They can ask in the exam, all of the following are immediate care steps recommended by NACO 21 except the fourth one will be your answer of choice. सो फर्स्ट इज इमीडिएट केयर एट बर्थ. अब उसके बाद द चाइल्ड इज बॉर्न, तो क्या करेंगे, फीडिंग स्टार्ट करेंगे. व्हाट इज द मेथड ऑफ फीडिंग? सो सेकंड इज इन्फेंट फीडिंग इन अ HIV exposed infant. Now, broadly speaking, there are two types of feeds which can be recommended in these children. So two types of feeds can be defined. One type of feed is called as exclusive breastfeeding. So the first type of feed is exclusive breastfeeding. तो सिर्फ breastfeed करवाना है, also sometimes called as EBF. And the second type of feed that needs to be given in these children is that can be considered is exclusive replacement feed. Exclusive replacement feed is also called as ERF, right? Either exclusive breastfeeding or exclusive replacement feeding. According to NACO, ये दो options हैं. Exclusive replacement feeding is also called as exclusive formula milk feeding, but that term is avoided in NACO. So which one is to be preferred? According to NACO 2021, exclusive breastfeeding is the one which is to be preferred. Potential MCQ point. कौन सा prefer करेंगे? In Indian context, it is the exclusive breastfeeding which is to be preferred. Now, a lot of students might think, sir, breastfeeding can transmit HIV. Yes, it can. But if the baby is on ARV prophylaxis, mother is on ART, and the child is breastfeeding, the risk becomes significantly less, and it is always better that you breastfeed the child. So risk versus benefit ratio, if we see, NACO says that you should recommend exclusive breastfeeding. So then the question will arise, obviously, when will you recommend exclusive replacement feeding in HIV exposed infant? First of all, you will recommend it if the breastfeeding is not possible in the child. So if breastfeeding is not possible, obviously you will go in for exclusive replacement feeding. And second reason, it will be recommended if it is a conscious decision of the parents. So if it is a conscious individual decision taken by the parents of the child. Suppose the parents themselves say, we don't want even 0.01% risk of transmission via breast milk. We only want to give replacement feeding. So in that scenario also, replacement feeding can be given to the child. But while recommending exclusive replacement feeding, you should ensure that the parents have a good socioeconomic background so that they can afford the formula milk. Agar afford nahi kar payenge, it is not going to be effective. Secondly, they should have access to clean water supply and sanitation. Thirdly, there should be a proper family support available. Sometimes the father will be working, mother will not be sick, or she will be sleeping. There should be family support to prepare the formula milk and give it to the child. And fourth, the family should be motivated enough that only replacement feeding they are willing to give for next few months. So if all of these decisions are there and the family decides that we want to give replacement feeding, according to NACO, you can give replacement feeding. So keep these points in mind. I'm not writing because I don't want to overburden you with unnecessary information. And this is a very, very important point. As per the NACO 2021, if when I was a student like you, we used to read that मिक्स फीडिंग इज कॉन्ट्राइंडिकेटेड, राइट? मिक्स नहीं करना है क्योंकि उससे चांस ऑफ इन्फेक्शन भी हो जाएगा एंड ब्रेस्ट फीडिंग भी कंप्लीटली नहीं मिलेगा. बट अकॉर्डिंग टू नेको 2021 इट क्लियरली सेज दैट मिक्स्ड फीडिंग इज नॉट कॉन्ट्राइंडिकेटेड, right? So write down, as per NACO 2021, the mixed feeding in these children is not contraindicated. It is not contraindicated, right? What does it mean? Preferable नहीं है. Preferable क्या है? Exclusive breastfeed. If that not possible, exclusive replacement feed. But practically, if someone is giving mixed feeding, would you stop that? The answer is no. The guidelines very clearly say mixed feeding is not preferred, but it is also not contraindicated. You can allow mixed feeding provided ART is being received in the mother and ARV prophylaxis is being given in the baby. अगर ये दोनों चीजें हो रहा है and some milk is being given along with replacement feeding, that can be allowed. So mixed feeding can be allowed if these can be ensured in the child. Basically guidelines क्या कह रही हैं? Simply breastfeeding best है, otherwise replacement feed, but end of the day some milk is better than no milk at all. This is what the guidelines say. So very, very important. Evidence भी मैं दिखाऊंगा. Now the recommendations also say, look at the snapshots, that NACO guidelines say that exclusive breastfeeding should be provided to all HIV exposed infants, and 6 months के बाद you should start complementary feed. However, given the fact that breastfeeding still carries some risk of HIV transmission, individual pregnant women should also be informed about alternate infant feeding option. तो inform करना है, and if they want to go for exclusive replacement feeding, they can go for it provided the conditions I discussed are fulfilled. Which is to be preferred for MCQ point? This is the one which is to be preferred. And the third important thing which is very frequently asked in entrance exam is ARV prophylaxis. ARV means antiretroviral prophylaxis. First thing to remember is all HIV exposed infants have to be given ARV prophylaxis, right? अब कितना देना है, for how much duration you have to give, that depends upon whether it is a low risk infant or a high risk infant. To define low and high risk, what we do is in every pregnant female who is HIV positive, between 32 weeks of pregnancy and delivery time, we do the viral load in the blood of the mother. If the viral load, the plasma viral load is less, we call it as a low risk infant. If the testing is not done, or the mother is newly diagnosed, or the viral load is not suppressed, it is high, we call it as high risk infant, right? So infants who are HIV exposed can be divided into two groups. We call them as low risk infant, right? And we call them as high risk infants. Now, as I said, which are the low risk infants? They are those in which the mothers are having a low plasma viral load. How much is the low plasma viral load? It is less than 1000 copies of viruses per ml, right? And this should be done after 32 weeks of pregnancy. So after 32 weeks of pregnancy, these babies will be called as low risk infants, right? Who are the high risk infant? As I said, high risk infants will be any one of the following. If the HIV positive mother is not on ART, the baby will be high risk. If the maternal viral load has not been done after 32 weeks of pregnancy, that is also high risk. If the maternal viral load is not suppressed, that is the viral load is still high, it is more than 1000 copies per ml, that is also high risk. And if the mother is found HIV positive within 6 weeks of delivery, the baby is called as high risk. How to define low risk and high risk infant can be a standalone MCQ for your exam. तो पहले हमने define किया low risk and high risk. Now what are the antiviral drugs that we are going to give? In low risk babies, you are going to use you can use either syrup nevirapine, or you can use syrup zidovudin. So oral nevirapine or zidovudin can be used in these children. दोनों में से एक. So monotherapy is given in low risk infant. And what is the duration? In these children, the duration will be from birth, starting from birth, daily it will be given till 6 weeks of life. So 1.5 महीने तक you have to give daily either nevirapine or zidovudin. In case of all the high risk infants, you are going to use a combination therapy. When I say combination therapy, you will combine both nevirapine along with zidovudin. दोनों को combine करेंगे and both will be given on a daily basis. What duration you will give? That will depend upon the type of feeding in the child. In case of combination therapy, remember that if the child is on exclusive replacement feeding, the risk is low. So you will give for still 6 weeks of life, starting from birth till 6 weeks of life. If the child is on exclusive breastfeeding, you will give from birth till about 12 weeks of life. This is very, 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 very important, right? So क्या देना है, कहाँ देना है, and what is the duration? In low risk, the duration is irrespective of the type of feeding. In case of high risk, if it is ERF, exclusive replacement feed, 6 weeks देंगे. If it is exclusive breastfeed, तो 12 weeks देंगे. So combination therapy recommended in high risk infants. Very important, add it to your notes. Moving further, like there are a lot of facts. I don't want to overburden you with information, but remember that for monotherapy in general, पहली बार baby diagnosed हुआ, mother is freshly diagnosed, low risk infant है, usually nevirapine is preferred over zidovudin. So which is to be preferred? Nevirapine is to be preferred over zidovudin for monotherapy. However, there are certain scenarios where zidovudin is preferred over nevirapine. What are the scenarios जहां zidovudin prefer करेंगे? If you are suspecting HIV-2 infection, it is rare, it is milder, but it is found that zidovudin is more effective in them. So HIV-2 infection अगर diagnose हुआ है, ये rare होगा, बहुत rare होगा. Then you will do it. In case you are finding HIV-1 plus HIV-2 infection, ये तो बहुत ही rare है. Suspected का मतलब it is there in the mother, so obviously you will be suspecting in the baby also. It is also a very rare scenario. Third scenario will be where the mother, pregnant female, has already got nevirapine in previous pregnancy. So she has already got previous pregnancy nevirapine, so we will not give nevirapine in the present pregnancy. Zidovudin should be preferred over nevirapine. And fourth scenario will be where will you give zidovudin preferably and not nevirapine? If the HIV positive mother is having treatment failure and is on protease inhibitors. So if she is on protease inhibitors, then again nevirapine will not be preferred. Zidovudin is to be preferred. It is to be recommended. So zidovudin kahan denge, nevirapine kahan nahi denge? These are the four scenarios which are mentioned. I am saying in a simplified form, so if your difficult option comes, you can always reach the correct answer, right? Now, what about immunization and vitamin A supplementation? Remember that these are HIV exposed infants. They are not positive yet. So all of them, they need to be vaccinated. So vaccination has to be done as per the national immunization schedule. So what are the individual vaccines? Remember first thing that all inactivated vaccines are found to be safe in them, right? PCV, the pneumococcal conjugate vaccine, is also safe. That can be safely given. Also remember that rotaviral vaccine, even though it is a live attenuated vaccine, it is a very completely attenuated vaccine, and NACO guidelines say it is also found to be safe in most of the HIV exposed infants. Regarding BCG vaccine, remember that BCG should be given at birth. It should be given at birth in all HIV exposed infants. However, the guidelines say there will be certain children who will not be given BCG for some reason or the other. If not given at birth, then you should investigate the child. Whenever investigations I will discuss with you, if the child is found to be HIV positive, you will give BCG only when ART has been started and the CD4 count is more than 25%. Then in these patients you will give it. If it is HIV negative, then it can be safely given. But in all vast number of HIV exposed infants, you can safely give BCG vaccine at birth. Regarding hepatitis B, remember that hepatitis B can be safely given. Hepatitis B vaccine is safe, but may need boosters. Many times the seroconversion is not proper. Many times the immune response is not proper and may need additional boosters. And lastly, about measles containing viruses, measles, rubella virus, they should be again, measles is usually given around 9 months of age, right? So 9 months tak to hum already testing kar chuke honge, we would have already done the testing. So measles is contraindicated if child is HIV positive and CD4 count is less than 25%. What it means is if the baby is HIV positive and the CD4 count is more than 25%, you can safely give measles containing vaccines. So this is according to National Immunization Schedule. And lastly, vitamin A supplementation should be given as per NIS. As per National Immunization Schedule, vitamin A can be safely given in these children. Then regarding monitoring growth and development, sometimes statement based questions examiner can ask you. So all HIV exposed infants, they will require weight needs to be done at every visit to hospital or ART center. Length needs to be measured every 3 months, and you need to plot on WHO standard growth charts. For weight, you should be using the weight for age charts, and development assessment needs to be done for all domains of the milestones, right? And the next thing is Cotrimoxazole Prophylaxis. Remember that Cotrimoxazole Prophylaxis needs to be given in all HIV exposed infants. But we don't start immediately at birth. It is started around 6 weeks of age. So you can write down that according to NACO guidelines, Cotrimoxazole prophylaxis needs to be given in all the HIV exposed infants, right? All HIV exposed infants you have to give it. And it is started at about 6 weeks of age, right? So it is started at 6 weeks of age, and the dose is standard dose. It depends upon the body weight in the child. So the dose is 0.5 mg per kg body weight given once daily orally. So you can write down the dose is 0.5 mg per kg given once daily, right? It is as per the body weight. Now, once you have started in all children, once it is started, all babies you have to give at least till 18 months of age. This is the time during which by which you can be sure that the patient is HIV negative and there is no risk of some latent infection being there and being diagnosed later. So at least till 18 months of age you should be given, and if HIV negative status is obtained at this age, you can safely stop it. If the child is found to be HIV positive at any stage, you will continue giving Cotrimoxazole prophylaxis at least till 5 years of age. So कब start करना है, कितना dose, till what age you have to give it is HIV negative, and till what age it is to be given if HIV positive. That are the things that you need to add. And then comes the most controversial thing, how you are going to do diagnosis in infants and children. First category we'll be considering is below 18 months of age. Timing is, the mnemonic for that is 6-6-18-3. First of all, we should know what is the investigation of choice. Earlier, the investigation of choice used to be PCR, DNA PCR for HIV-1. Right now, it is not DNA, it is TNA, total nucleic acid PCR, which is done, and that also on a dried blood spot sample called as DBS. So write down, it is the potential one-liner for all the entrance exam you will be sitting for. The investigation of choice for diagnosis of HIV in children below 18 months of age, for initial screening, obviously, we do it as dried blood spot, right? Dried blood spot, also called as DBS testing. When we do DBS, what do we test for? We don't test for DNA PCR, we test for TNA PCR in the child. TNA stands for total nucleic acid. इसमें DNA भी आता है, इसमें RNA भी आता है. So TNA PCR, dried blood spot. And what is the timing you are going to do? First test DBS is going to be done at 6 weeks of age. Then antibody testing is to be done at 6 months of age. Then repeat antibody testing to be done at 18 months of age. And then last testing should be done 3 months after completely stopping the breastfeed. So the mnemonic for that is 6-6-18-3. What does it mean? Let us write down. I'll simplify it. It is much more complex than what I'm mentioning here, but this will serve your purpose. So at 6 weeks of age, remember that at 6 weeks of age, you will be doing a dried blood spot sample for DNA PCR. Right? Now there will be two possibilities. या तो negative आएगा. If it is negative, nothing to worry, only observe the child. Right? If it is positive, you will repeat DBS. एक पे positive नहीं बोलना है, repeat DBS. If it comes to be positive, so 2 DBS have become positive, this was also positive, this is also positive, you will say the child is likely HIV positive. You will start antiretroviral therapy in the child. If the repeat, पहला वाला तो positive था, दूसरा वाला negative आया, so what you will do? You will do a third DBS. और इस पे जो भी आएगा, that will be a best of 2, best of 3, and you will decide what is to be done, whether HIV positive label karna hai or HIV negative, here to be started or not. That will depend upon the third DBS. So 3 times testing may sometimes be needed. So scenario based questions can be asked. Second thing will be at 6 months of age. So all children, सबसे पहले तो 6 weeks पे किया, then 6 months of age, you will be doing a serological test. It will not be a TNA PCR test. You will look for antibodies. So you will do serological test for HIV antibodies. You will do a serological test for HIV antibodies. These are nothing but rapid diagnostic tests, also called as rapid tests. Now, there will be two possibilities. Serological test kiya negative. If it is negative at 6 months also, you would say the patient is not infected, right? And in case they are found to be positive, now you will do a DBS and decide. Now here again you will do a DBS and decide in the patient. So you will do a DBS for TNA PCR and decide whether it is negative or if it is positive. If it is positive here also, then both of them are positive, you will label the child as HIV positive in the child. Then third testing will be done at 18 months of age. At 18 months, same testing will be done. Serological testing should be done. So based upon that, negative and positive, you will take the call. So same serological test, what we have done, that will be done at 18 months also. And fourth will be the last testing should be done 3 months. The last testing should be done 3 months after completely stopping the breastfeeds. Completely बंद कर देने के बाद. So 3 months after completely stopping breastfeed, whenever it happens, right? Because जब तक breastfeed will continue, there will be a chance of the child likely to get HIV infection. The guidelines also say कि अगर suppose दोनों coincide कर रहा है तो ऐसे लिखते हैं whichever is later, right? So whichever is later, this is regarding the diagnosis. I know this is very simplified form I'm telling you. There will be a lot of questions in your mind, but it is a simplified version of the complex flowcharts and the description given in the NACO guideline. So what they're basically saying is that before 6 months, you will not be doing any HIV antibody test. It will be DBS which will be done. 6 months onwards, serological test can be done, but alone serological test is not sufficient to call the child as HIV positive, because there can be maternally transmitted antibodies also. So there, if you get a positive serological test, you will do a DBS and then decide. So DBS तो करना है, लेकिन कैसे करना है? Alone DBS या with serological test? That is the difference. 6 week, 6 month, 18 month, and 3 months after completely stopping breastfeed. Right? About older. So to summarize again, below 18 month of age, HIV exposed child, all children 6 week पे DBS करना है, right? 6 month पे serological test करना है, but serological test for antibody, even if it comes positive, you will not label the child as HIV positive, you will do again a DBS, and if DBS is also positive, then you will label the child. Then 18 months of age, you have to do again antibody testing, right? Serological test करना है, and last test should be done 3 months after breastfeeding has been completely stopped. This is what the protocol is, right? Details obviously you can go through in the detailed protocol which is there. It is just a revision video, so I'm summarizing from exam point of view. About older children, questions can be asked. What about children aged 18 months or older? They are tested according to the national reader testing strategy. So हम इसमें serological test करते हैं, which includes tests like ELISA also, and 3 tests are usually performed. So child is diagnosed as HIV infected if symptomatic बच्चे के अंदर, symptomatic child, इसमें any 2 tests are positive. So 2 separate tests on antibodies, they are positive, we say child is HIV infected. Or if asymptomatic child is having 3 HIV antibody tests done sequentially found to be positive. So symptomatic में 2 tests, serological test positive. Asymptomatic child, 3 tests if they are positive, we say it is HIV infected, and you will start antiretroviral therapy in the child. You can stay in touch. In episode 2, which will be releasing in about 3 days from now, I will be coming up with another important topic, and trust me, it will be shorter. This was the shortest I could make this topic. Thank you very much.